Tēnā koutou katoa. Ka mihi mai o ha kia koutou katoa. Nau mai, haere mai, tēnā tātou katoa. Nō reira he karakia timatanga. E te huinga whaia te maturanga kia marama. Unihia te ani pā, te nguha kia māhia, kia whai taki ngā mahi katoa, tū maia, tū kaha, aroha atu, aroha mai, tātou ia tātou katoa, hui e tae ki e. Tēnā koutou katoa, toa rua ki ngā mate haere moi mai rā, i te hunga ura o te ao ora, tēnā koutou katoa. Tua tora kia ka mihi ki te iwi kāinga kia mu o pōko, Ngāti Raukawa ki te tonga. Kia tātou i tau nei, kua tae mai ki te kaupapa nei tēnā koutou katoa. Nō reira i te whānau, tēnā koutou, tēnā tātou katoa. Welcome everybody. Ko Jane Cullen, toko ingoa, Lead Advisor, Quality Improvement here at the Health Quality Safety Commission. Thank you, and I'll hand over to Gillian Bohm to start us off today.
Tēnā koutou katoa, everyone. It's really fabulous to see you all joining us as you come on in. I want to give a very warm welcome to everybody on behalf of the Health Quality and Safety Commission, and also on behalf of Dr. Janice Wilson, our Chief Executive, who's unable to be with us today. We really appreciate your support and hope you will enjoy the sessions today. We've got two fabulous speakers for you and really looking forward to it. I'm Gillian Bohm, the Chief Advisor, Quality and Safety at the Commission, and look forward to doing that. So we've got limited time, so let's go off to our speakers so we can use them to the best advantage. The first speaker today is Dr. Carl Horsley. Carl is an intensivist in critical care complex at Middlemore Hospital and the clinical lead for system safety with us at the Commission. Carl's been engaged in many national quality improvement projects and has shown great leadership in terms of this, hence why he's recently completed a master's degree at London University and has, along with the interest he's shown and the networking he's done, become a real expert in resilient science. We really look forward to your presentation. Welcome, Carl.
Kia ora, Gillian. Thank you very much for that very kind introduction. Ko Carl Horsley tōku ingoa. It's lovely to be here today and to share a bit about the work we've been doing at the Commission. I'm just going to share. Here we go. So today we're going to be talking a bit about the background of He Toki Ngā Matariki Aotearoa. And this is the program that we have been working on for a while now, which is really about what does resilient healthcare, what does resilience engineering, these new ways of thinking about safety, look like for Aotearoa. So I'm going to give you a bit of background about how we got to this place. And some of you have seen my talks before, and hopefully there's a bit of nuance that you can understand about how we get to where we are now. So currently, a lot of our approaches in our healthcare system are really based around the ideas of the 1990s around health productivity and production. And so very much we see a big focus that has been put through about efficiency and effectiveness and really about how do we push more people through a straining system. And so when we have this kind of approach, this almost industrial approach since the mid-90s, is we kind of have this idea about how healthcare happens, which is that people turn up, they go through the system, they get treated, and off they go again. And when you think about healthcare as an industrial activity, as essentially about doing more for more people faster and quicker, we become very focused on certain things. We get focused on outputs. How many cases do we see? What's going on? We think industrial ways in terms of that safety becomes then about reliability. How do we make sure that everyone gets exactly the same thing every time? Our focus becomes on bureaucratic constraint about how do we make sure people are doing the right thing, how do we check on them, how do we have control systems to make sure that that's happening. People within the system, unfortunately, are therefore seen as really components or products. Staff, the components within the system, we need to make sure they're well trained, we do all these things, but we upgrade the components by doing those things. And often patients are really the product of the system. They're the bit the widget that moves through this industrial process. And it also has implications for communication in terms of we just need to make sure that people are doing the right thing. We send orders from the ministry or from the commission or wherever it might be. And basically, it's a transmissive model of communication. Here's what we need you to do. And in this model, very much safety is then seen as something where, the normal function of the system is that it's safe, and that really the only problems that we have are really when there are unacceptable outcomes, failures, malfunctioning, people don't do what they're meant to do. And that's where we put all our attention on for safety. And we see that really with many aspects of adverse event learning and also with HTC and other things that are going on in the system. And the aim of safety in an industrial approach is really that as few things as possible go wrong, that we minimize the things going wrong. There's some really interesting and curious kind of side effects of this approach, which really come back down to this idea that, well, if there's no harm, there's no problem. So we pay attention to these harm events, but we're not really interested in about how risk is changing, what's going on. As long as the numbers look okay, then we're sort of blind to that kind of what work is being done to keep the system going, the work that people are doing. It means that because we focus on safety as being the same as reliability, we're very focused on constraining the performance of the system. So we add in more and more checklist audits, whatever they might be, but ways of constraining the system. And that's palpable on the workforce, for the workforce. And this leads, unfortunately, to quite bureaucratic approaches to safety often, where we have proceduralized approaches. And this drives a secondary phenomenon, which is really that we kind of focus on bureaucratic closure sometimes. Have we done the report? Have we sent the part B in? Have we done all these things? Rather than what have we learned and what have we changed? And as part of this, we also see that there's a big emphasis on rituals of verification, audit. Have we fixed the problem? And the trouble with this is that really we then end up with this, when we're looking at events from this model, is that we also have a problem where we have an illusion of learning, where when we think about what's going on for this person here, a clinician who's navigating a system of making decisions, when they make the decision, their aim is to get the patient through the system, to achieve the goals, to keep them safe, and they make the best decisions that they think they can at the time. But in hindsight, what we see is the choices people make and how it led to an outcome. And we are blinded somewhat by hindsight bias, this understanding of looking back and telling a story that leads to an outcome. And also the judgment that comes from knowing the outcome, the poor outcome, of how we judge people's actions in the moment. So we're subject to outcome and hindsight bias. And so the problem here is really one of simplification after an incident, which doesn't reflect the complexity and the realities of people who are doing the work. But because we have this approach, and we've written a report and we write something, we have this illusion that we have learned something, that we have fixed something. And very often this means we end up discussing what didn't happen, what the staff should, would, or could have done, rather than trying to explain what they did, trying to explain what actually did happen. And this is the other thing we see, is that often there's some faulty assumptions built into this. If you have a perfect system that's working really well, then you assume the system will function into the future if we just keep doing the same thing, that the past is the same as the future. It also implies that sometimes that we can do, pilot and scale. We can do one thing one place and we can just roll it out and work the same place everywhere else, that everywhere is the same. The context doesn't quite matter. It's just the industrial process will flick it through. And that the people within that system, the patients, have the same needs. And one of the things we've really seen is that this approach also makes things brittle when we don't understand the adaptability and we suppress innovation through, this focus on constraint, is that when things change, when conditions change, then suddenly we've got a system that's really set up to not deal with that adaptability and innovation. And we've seen this with COVID, whereby, what was required was this massive reconfiguring of the system. And actually that was something that was not how the system was set up before that. The other bit that we have in this approach is really that we don't meet the needs of those harmed, and reports from the HCC and adverse events, when you talk to families, that often their needs aren't being met by our current approaches when we just go back and say, what did people do wrong? Here's what they did wrong, write a letter, write a new policy. We're not really meeting their needs, that we're not hearing what the harm was. So it's not really that surprising that we have problems with staff burnout and patient disengagement. We have systems designed around tuning more and more people through in a system. We're blind to the risk that's happening, and we're not really understanding the needs of the people within the system. And when we think about this, then we start to see that issues such as safety and equity and productivity and quality improvement, the limitations that we have with trying to affect real change, the burnout issues we face, the staff engagement problems we face, and patient experience, we kind of face with all these problems all at once. And these are creating a lot of stress in the system at the moment. And I guess what we want to talk about today is really about why is that? What is the thing that links these problems together? And this comes from Brené Brown: when we fix the wrong thing for the wrong reasons, the problems continue to happen. And I guess that's one of the things, is think about with some of the problems we're really struggling with, what is it that holds them in that way? What is it that keeps making it so? So let's just take a step back. When we think about simple systems, even complicated systems, they're decomposable. A car is complicated. We can take it to pieces, we can fix the broken component, we can put it back in, and that's fine. That's a complicated system. You can fix just the component or one little piece of it, and it has no impact on the rest of the system. But healthcare is not complicated, it is complex. And it really depends on where we look at it. And I understand there are some bits that are less complex, but all parts of the system at times will go through change and dynamic shifts of risk and interactions. And so at all stages and all parts, healthcare is at times complex because it is a massive, big heaving system. And when we think about complexity, what we focus on then is not about just the components, but about the interactions between those components. We don't focus on just the person. We think about how is the person informed by their context, their environment, their tasks, the tools they get to use, the organizational culture. And when we do that, we have to focus then, start thinking moving away from thinking about components of the system to much about the relationships in the system between the people who co-create care, between the people and their work systems, about how are people shaped by their environment, and thinking also about the relationships between different institutions and different parts of the system. When we think about complex systems, we have to understand that the whole is other than the parts. It is different to the parts. So, for example, describing all these different parts, the human doesn't explain who I am as a person. There is something other than. And that's the same when we think about systems. When we take a particular component and we add another component, that doesn't tell us about what is achieved as a whole. So an emergency department is quite different from just putting nurses and doctors and other people in a room. There's something other than. And so we can't explain things just by looking at components alone. And this really means that when we're thinking about how we want to look at a problem, we need to be thinking about the system as a whole. So, and we'll talk about system boundaries, but essentially we need to understand the way these things all come together in relationships, because we can't just understand components in isolation. And healthcare is really, and this has been really seen the last sort of few years, we're operating in this volatile, uncertain, complex and ambiguous world where the problems we faced in the past about health spending and efficiency gains and productivity and stuff really were sideswiped by a massive pandemic that changed so much of the work that we had to do. And that the future was certainly not a good was not represented well by the past at all. And so when we see this, we start to see that actually in this dynamic and uncertain and complex world, that the messiness of everyday work, the work as done by people who are doing the work, is quite different from how we imagine it in the policy, procedures, guidelines, or by people who don't do the work. And really, when we think about this, is the way that people navigate complexity, the way they cope, is by making trade-offs. They have to navigate, what is the risk that we see here? What is it we're trying to achieve? How do I do that? And they're constantly making efficiency and thoroughness trade-offs to keep the system going, to keep it safe enough. The other thing with complex systems is that outcomes are not resultant. It's not this leads to this leads to this. It's not the Swiss cheese of the holes lining up. It's more like the perfect storm of all these conditions coming together and creating an outcome. And this really comes back to the idea that that there are emergent behaviours, there are complex behaviours that arise from the interactions within the system that are not predicted by just looking at the relationships that we normally do with the linear things. And so we really need to stop thinking about, the 5 whys and really think about the 5 hows. How did this happen? How did these things come together at this time to lead to this outcome? So when we move to this model, we start to see that safety is more about the fact that people are constantly creating safety as they navigate complexity. They're making decisions to try and get the best outcomes they can. And that most of the time that works, otherwise we wouldn't do it, but sometimes it doesn't. And so we need to think then less about how do we restrain people and more about how do we dampen down unwanted sources of variability and how do we enhance the ability for the system to adapt under changing conditions. So the new aim of safety is really that as many things as possible go right. How do we create the conditions for good work? So when you change your perspective, you start to see very different things. And a move to system safety is really this idea that the Commission is now moving to this focus on system safety. And a system is really an interconnected set of elements that coherently organize to achieve something. So there must be elements, connections, and functional purpose. And it's not about people or systems, it's about people in the system. So seeing people within the situated context in which they work. That means we need to be thinking about the work systems that people work in, the technology, organization, tasks, and environment they work with. But also we need to start thinking about the social systems in which people work and not just looking down here at the staff and management, but also the way that regulators and funding affects and creates the context for work. It means we need to be supporting the conditions for success. And for quality improvement, this is vital. How do we make success more likely? And that means understanding the realities of work in the different contexts. So what works in a busy, minimal ICU is not going to work the same way in a community provider. And so we need to understand the realities of that work situation. And this really comes down to the idea about bringing in human factors into economics, about this focus on both human well-being and system performance. And we're starting to do this with the Commission now, working with the WorkSafe and the Human Factors Society to bring in human factors training into healthcare. And with WorkSafe, this really is their focus now on better work. How do we design good workplaces? Understanding that really the provider satisfaction, the provider sense of the work they do is the underpinning of the other 3 parts of the AAA. It means we need to be learning different lessons. Rather than sitting back and judging people in retrospect, we need to be understanding how did what people do make sense to them at the time. And really this is about putting ourselves in the situation of that person and asking ourselves, why did that make sense? Could someone else in that same situation make that same choice? And it means that we need to move from just focusing on the incident to much more understanding about the way that is shaped by the context, government, regulation, media, all those things. And we need to focus on meeting the needs of those harmed. And that's something we're not doing now, but it's the work that's going on with the Diana Unwin chair, with Joe Welling, and restorative practice. And this work is also ongoing in our adverse events policy review, and I hope that all of you will have a say on that. The other bit is about really how do we build resilient systems. This is not about individual resilience, more pizza, more yoga. This is about the capacity of our system to adapt to challenges and changes and opportunities at different system levels to maintain high quality care. And we saw this particularly in community providers, Māori and Pacific in particular, where I work, as they responded to really adapting to how they normally work to respond to this unheralded event. And what was prominent in this was it was all about relationships, learning from each other, seeing value in the different viewpoints, the different ways of seeing, and working together on the shared problems, and enhancing the mana of all those involved in those relationships. For leadership, this means this is a real challenge. We have to move away from command and control to really think about what is it we're trying to achieve? How do we create the space for people to contribute to that work? And how do we balance creativity and constraint? And when we think about data, which is a really big part of the Commission's work, is about what do we measure and who is it for? Data is for what? And are we using it to build an understanding of our system? And for us in the Commission, we're now starting to work out how do we build these relationships across the sector. So working with ACC, HTC, WorkSafe, all these organisations to try and put together a more coherent understanding of the work that we all do together. So He Toki Nao Matariki Aotearoa is really, a toki is an adze, a chisel, an adze to cut away, to form, to make. And Nao Matariki is the finest work, the most important work in the things that we do. And really this is about the idea that this is an overarching framework when we think about how does complexity change the work that we do in system safety. And we are the new builders of the waka. And this is a name that was gifted to us by Huataki Whariatu from Ahuahi Kauniki within the Commission. And so when we think about this industrial approach now, we're thinking about this idea that's focused on outcomes, safety as the ability to match conditions, balancing creativity and constraint, the people as the purpose, and communication as co-construction. It is human-centered. It meets the needs of the people within the system rather than just the needs of the system. It's built on understanding that different contexts need different solutions. And it's about the relationships between Māori and the government and Crown, but also across the sector between different parts of the system. And bringing together these multiple viewpoints to better understand, to see different things, and to answer the question, what is this care that we build together? For quality improvement work and safety work, it's about meeting the conditions, understanding where we can use reliability, but where we need to start thinking quite differently about work. And really moving from this loading up the adaptive capacity of the front line to much more think about how does the system as a whole recognize changing conditions and respond as a whole system. And I think one of the really big things I want to stress to you guys is that really this focus, that I think the secret weapon for Aotearoa is really that we live in a Māori world, and Māori have been dealing with issues of navigating complexity and relational ways of working and interconnectedness. That's central to Matarangi Māori, and so this is something I think that we have as a real benefit here. And the question is not to say resilient healthcare is the same as Matarangi Māori. It's to say we have these different kaupapa. How do we bring them together to create something even better? How do we lead the way on this? And I really believe that New Zealand, that we can take some of these modern safety ideas about coping with complexity, and we can see and use Matarangi Māori to really lead the way internationally. This is my hope for a lot of this program. Finally, I'd like to say no work ever occurs in isolation. This work has been led by the System Safety Team of the Commission, the Ahuahi Kauniki, our partners in that, but also participants of the Resilient Healthcare Aotearoa Hui that we held last year, and many more across the motu. So my thanks to all of you. Thank you very much.
Thank you, Carl. That was fantastic. So we'll allow questions. If anyone wants to type into the chat their questions or raise their hands, we'll go to those questions. Just while we wait for people to type in their questions, I was just wondering, when you were talking about the different approaches and how we have all these tools for complicated systems and we need to move to these tools for complex systems, I wondered if you could maybe describe how we would know which is the right tool for the right problem.
It's one of those things where very often like a simple model of something, which is a fairly linear system, it's going to work really well. So, it works well enough. I guess the things are when you're having problems that keep repeatedly happening despite the interventions, will you reach a threshold and then they stop working in the way you would hope for improvement, then I guess that's the time I start saying, are we using the right model? And Falls is a really good example of that. The initial work was focused on, how to provide checklists and help, and that really, we got some really good improvement. But now we're facing the problem of trade-offs with safe staffing and the availability of HCAs, and the trade-offs between how do we get people out of hospital faster by encouraging their autonomy and movement and mobilisation versus the risk of falls. And how do we deal with that with the settings that are really not designed for rehabilitation? And so I think that those are, when we're having problems, particularly the ones that are really we're struggling to fix, then those are the ones that I think we need to be thinking quite differently about a system approach rather than just taking things in isolation. It doesn't mean you can't do that. We don't have to abandon previous QI tools. It means we have to think about which context, which problem am I dealing with here.
Fantastic, thank you. I did see someone with their hand up, had a sort of cryptic name under that, so FTIN or something along those lines, had their hand up. F Mitten, FMITNN had their hand up. Where have they gone? Can you highlight them, please, Hamid?
It's like a name and shame.
No. Okay. Right. In the meantime, what do you think is holding us back from working in this way more often? I think,
Yeah.
we've been working in the constraining approach for quite some time. What's holding us back from moving to this way?
In the history of safety, I mean, where we are is, where safety thinking was at in the 1990s. That's entirely appropriate. That's where we started. That's what informed a lot of our systems. The HDC was formed in the mid-90s reforms. Some of our thinking about RCAs and things was formed in the late 90s based on James Reason's work. So, it makes sense that we're in that space. That's fine. And it's very common in many other industries. But I guess that's a really interesting question. What is it that holds us in our current approach? And this comes down to the idea about, structures that hold us. If we assume that everything we're seeing at the moment, equity, if we see equity, if we see staff burnout, if we see, patient experience, the problems that we're having with that and the problems with learning as the outputs of the system as it's currently designed, then one of the really interesting questions is what holds us in a system that does those things? What is it that we pay attention to and value that holds us in that way of seeing things? And without making those trade-offs visible, it's very hard to fix them. So I think that there are many things both in the way that our safety learning systems are set up, and the way that the HDC is set up, and the way that we think about funding models and the reforms, and the structural elements, the DHB and the ministry relationships. There's lots of things that do that. And I think the reforms are a really unique chance for us to think much more coherently about what does it look like across the whole system? How does information flow up and down? How do those making decisions about funding or policy understand the realities of work in different contexts, not just the DHBs or the hospitals, but in all across? And how do we put those together in a coherent way? Which problems are best solved at which level? And that's something that's quite tricky, but we're only a 5 million, person country. We should be able to do this. And this is the move that places like NHS and Scotland are moving towards, and other places around the world.
Right, we have had a question come into the chat from A. Bruce. Can you explain the rationale of the HQC move to system safety?
Yeah, great. Thanks for that. It's a really good question. So previously, when we talked about patient safety, one of the worries with that was we treated the patient as object, and we talked about that, and it was blind to the problems of the system, and it also meant that we didn't. It kept everything centered very much on the patient, which is really good and how it should be. But it wasn't about meeting their needs; it was about them as the object of safety investigations. We're also blind to the role that staff safety and staff wellbeing have in that, and it drew all our attention into who was closest to this event when it happened. So system safety is really trying to acknowledge the fact that it's much more about seeing this whole system, this healthcare system, as about what creates the conditions that allow patient harm to happen, but also staff harm, but also waste and inefficiency, and also, the lack of ability to adapt when things change. So I think for me, the system safety basically just says our focus should be on this whole system and how it delivers for the patient, not just in terms of safety, but in terms of their experience of it, the way it's designed for them, understanding the differentiated needs that patients have, because they're not all the same. So to me, that's the move that we are trying to make. And I think the Commission has a key role in that level of thinking about the wider system, the architecture of the system, and how that enables or impedes information to flow.
So we've got a raised hand from Saratin Sumashni. So if they want
Hello.
to just unmute. Yep.
Hey, Carl, it's both of us here.
Hi.
Hello, guys. Nice to see you.
I got the mute on because we got a bad background. I'll put it on. Okay. Carl, you've been able to articulate and put into context, conditions of work and what we experience at work. That's difficult to address to sort of people that have the purse strings from the on the ground point of view. So I think that I feel like this new approach and things like that is going to need a lot of education. Delivering this concept to those who need to understand it, and therefore then see it trickle down to us at the grassroots level. What kind of time frame and how is there a plan to roll this out from a education point of view, as well as funding point of view, so that we start seeing some the benefits of this change in perspective of the healthcare system.
Yeah, thanks, Sid. It's lovely to see you both. I guess Charles Vincent said safety is what happens at the bed space, and I guess that's the thing, is when we reorient the system to say, how do we support good care, and how do all levels of the system support good care without understanding the realities of care as experienced by patients, or those who seek care rather, and their whānau, and the experiences of our staff, then we can't do that. And at the moment, there's not a great flow of information. And remember that it's not a one-way communication channel. It's not like, we just need more money and it'll be okay. We need to be having difficult conversations about the realities of, how do we redesign things to help. And so staff, we say, if we just have more staff, would be okay. What they mean is for the current way we work. And is that the right way to work? Or should we be having different conversations across the boundaries of primary and secondary care? The system as it is now is very fragmented. And, primary care is so separate to the DHBs. And from the patient point of view, it's their health. They carry their health needs throughout the system, but we work in a very disorganized and fragmented way. And so I guess it's one of those things about how do we come together to have difficult conversations. And the biggest change we can make, I think, is that change in the mental model about how is safety created, how is good care provided. And I think that's the thing we're trying to work on first. In terms of timeframes, I think the reforms are, they come in June, July. I anticipate several years of settling in. Would that be the phrase? And I think, we need to be thinking together about, well, what do we want from the system? How do we design an overarching safety framework? How does information flow? How do we make it coherent to those who have to navigate, ACC, WorkSafe, HTC? How do we meet the needs of people in those systems? So I think it'll be years. Sorry to say, but I think culture changes years. But remember, it's been stuck in this way since the mid-90s. So it's we've been in this way of working for a long time. It's not going to suddenly change.
Yeah. Thanks, Carl.
Thanks, Ken. Nice to see you.
Thank you for that question. Oh, you had another good question, long question from Caroline. Patient safety is key, but the term patient limits consumers of all healthcare settings seeing themselves. Our focus is on the whole health sector. Oh, it's not a question, it's an answer.
It's an answer.
Right, okay. I'll let everyone read that. I'm just going to ask you, you mentioned the contribution of Mātauranga Māori to our understanding of system safety. And I'm just interested to know if you see similar things happening internationally, or whether that's a unique contribution that we're making here in Aotearoa, New Zealand, to the understanding.
Look, I think it is, my hope is that it is something that we can embrace in Aotearoa. I think it's something that is a secret weapon. In terms of it's something we have that other places don't necessarily have. But if you think about places that everyone goes to look at, like is it Nuku in the Nuku health system, everyone goes here and says, wow, how do we replicate this? How do we do it? And it's all based on relational ways of working, about understanding what the needs of people are. But we can't then translate that back into the same Western systems if we're going to do a quality improvement model that rolls it out, in a Western way. Because a lot of Mātauranga Māori about this idea about the fact that we live in a world of relationships and connections, that what the Commission does has an impact on my work, that what the government does has an impact on my work, that we are connected to people with our whānau, with those things. That's quite a different view from this idea of the individual going through a system. And that's a lived change. That's a lived way of working. This understanding of what do you need from me, what do I need from you, how do we work together on this problem, what do you see that's different to me, and how do we bring that difference and we see it as a strength. That's a very, I think, a very Māori way of seeing the world, and I think that's a real strength. So, and I kind of talking to some of our colleagues in Ngāti Kainoku, they're sort of like, oh, it's great you finally got here, we've been waiting, like we're waiting for complexity to catch up with where we've been. And it's this organic way, relational way of working.
So I've got one more question, which will be, I imagine, the final question from A. Bruce again. Thank you for your questions. How do you see quality evolving with Health New Zealand and the HQC input into system safety for our population?
Whew, look, I think that's a really great question. There is so much change and so many things happening. And my hope is that it provides a chance just to think much more about, how do we see the realities and the system problems that are going on in different parts of the system, and how does that information feed up? There's no point the Commission knowing exactly what's going on in every emergency department around the country. That's not feasible, but it's more about how does information flow. I think there will be a need for an overarching approach to safety and quality. I think those things are still being worked through. It's probably above my level in terms of what's happening in the transition unit. I know that self-organisation is a wonderful thing in complex systems, and that people are already having conversations regionally about how they work together. But how do we turn it into a coherent system that means that we share and learn and understand what works for who under what conditions and how? Then I'm not quite sure how that is set up at the moment. And I don't know if Gillian or others have got some comments on that.
I'll hand over to Gillian because it's now time to go to the next session. If Gillian wants to slip in a comment as she leads into the next session, I'll leave that up to her. But thank you very much, Carl. It was fantastic.
Again, thank you, Carl, as well. I think the answers are long for with the time frame we've got now. So thank you ever so much from all of us. And I think we'll move over to our next speaker. So I have the absolute pleasure in introducing Dr. Mary Seddon. Here she is. Welcome, Mary.
Hello.
Mary holds fellowships in medicine, public health and medical administration. And she is the director at Koawatia, the Centre for System Improvement and Innovation at Counties Manukau Health. A Harkness Fellowship at Harvard Medical School sparked Mary's interest in healthcare quality improvement, and she has mainly focused her mahi for this over the last 20 years. We regard Mary as one of the leading thinkers on how improvement science can best be utilised in improving safety and quality in healthcare in Aotearoa, and especially her ability to think about how to do it now and also how to do it in the future, including the reformed health system. Mary, the warmest welcome to you, and we're really looking forward to your presentation. Thank you.
Kia ora tātou. I'm presenting this really on behalf of the county's radiology department in Koawatia. I'll leave you to decide which parts of this are complex and which are complicated. But we were really asked in to help the radiology department. Let's see if it'll go to the next. Ooh. There we go. Because they've had a steadily increasing number of patients waiting for their MRI scan. So nearly 2,000 patients on the waiting list and more than 200 waiting in excess of 6 months. The Ministry of Health target was 6 weeks, so we were well outside that. Along with that, we had major stress in the staff and problems with retention, particularly of MRI technicians. And what the service thought they needed was more of these technicians, and I think that's what Carl was getting at, that if they continued to work the way they were, they needed more technicians. But we were asked to come in and see whether there were other ways of working. So our aim was to reduce the waiting list to less than 500 patients within 2 years. And we started off by conducting a capacity and demand study to use these the findings of the study to guide further action. This was done, one of our improvement advisors was embedded, if you like, in the radiology department, working very closely with them. So it was work as done was what he was seeing. So we used 6 months of data and were able to show that the capacity of the unit, they had more than enough capacity to meet the demand, but that it was mismatched. And this started a completely different conversation, moved us away from we need more staff to how can we best utilize what we have at the moment. So in our driver diagram, we've got our aim statement, but we started to look at matching capacity to demand, segmenting the waiting list, and redesigning the system. Matching capacity to demand, some years ago, in order to retain MRTs and stop them going to private, many of them were working 4-day weeks and mostly having Friday or Monday off. So we had more than enough MRTs on Tuesday, Wednesday, Thursday, but not enough on Mondays and Fridays. So that was discussed and people tried to rebalance their rosters to match the peak periods. I won't go through all of this, but waiting list segmentation was probably, for me, the most innovative. We found that, there were 4 groups that contributed to these very long waits. Patients that needed sedation for their scan, pediatric cases that needed general anaesthetic, the need for interpreters, and also prisoners. So we actually started looking at what we could do, and I'll come to that, but what we could do to address that. The other thing that I found really interesting in this was we also segmented by body part. So if you are scanning a shoulder and then your next scan is a head, you actually have to take the coil out and change it. So these are elective MRIs. So we decided to do a whole list of shoulders, a whole list of heads. For the interpreters, we would run a whole list in Cantonese or in Tongan. And for the sedation, again, we would set up actual lists for that type of case rather than letting them just wait and wait and wait. So those made big differences. And I'm happy to talk about any of the other things. A greater role for MRTs was key to this. So at the end of 2020, we were able to significantly decrease the number on the waiting list. And even more interestingly, well, for me, we were able to move the list to the left. So the blue bars are December 18. And you can see we had 204 patients waiting more than 180 days. And the yellow is November 20. Not only have we decreased the size, but we have very small numbers now waiting excessively long times. So that made quite a big difference. And it was really exciting to see the radiology department with the feedback of data, taking this process on themselves. So if we just look at the stats, so just under 2,000, 1,950 in December, down to 413. Average waiting time, 96 down to 23. That's a big difference for a patient. We still had occasional patients waiting longer. But I think the other really important thing is the scanning hours per week went from 55 to 136. Middlemore has 3 MRI scanners. When they got the third one, they thought it would decrease their waiting list, but it didn't make much of an impact because it wasn't really utilised as well as it could have been. So with mapping their capacity to demand and showing and working with them and showing that we could make a difference, that was really where we were. So the lessons we learned, I think it's really important to understand the problem at the start. Whether it's a complex or a complicated, you really need to understand what is happening. And in this case, it wasn't actually a demand problem, but a mismatch problem. The other thing I think is really important is to allow data to drive the conversations. When you first start, there's a lot of beliefs and anecdotes, and they can lead you astray if you don't have good data to guide the conversations. And I think interrogating the waiting list, as I said, we found 4 groups accounted for the most extreme waits, so we could proactively set up lists for these groups and decrease the long waits. I think this is something that could be useful in many other lists. in medicine, we put somebody on a waiting list, and it might be a P2 or a P3, but once they're on the waiting list, we don't tend to look at that list and actively manage it. And I think that's something that we could do with colonoscopy waiting lists, surgical waiting lists, actually getting that science to start to look at that. And the other lesson is really engaging with frontline staff, and Ko Awatea's job really is to transfer the capability to continue quality improvement. We assist where we're asked, but we don't actually want to come in and do to a unit and then leave. So it's working with rather than doing to. I just acknowledge the radiology staff, some excellent MRTs, and we had support from the clinical director and the service manager. And I'd just like to call out Hera. He's left Ko Awatea, but he did much of the data under the guidance of Bernie. So I'll leave it there and take questions.
Thank you, Mary. So if people want to either just raise their hands or type in the chat for their questions, just while we wait for people to do that, Mary, I was just thinking about your talk about, you know, the mismatch between the capacity and the demand, and working with staff to manage that. And I was sort of also thinking about the quadruple aim and provider wellbeing. And I was just wondering how you managed the people factors with the changes that you implemented.
Well, when we started, we had co-located 2 machines plus 1 isolated. In the 2 machines, we had 2 techs for each scan. In private, they have 1. So we worked with the staff to say we could have 1 plus an HCA getting patients ready for you so that you are working at the top of your scope. The other thing was working with them to vet the referrals. Up till then, it was only done by 2 SMOs, so it was a slow bottleneck. The other thing was introducing unsupervised scans, so MRT-led scans, early in the morning and late at night when the SMOs weren't there, so that they could actually take some control and feel like they were driving their work. That being said, COVID really has impacted very strongly on this piece of work. It's really about giving people the authority to make changes.
Thank you, and that actually ties in well to what Carl was talking about. So I was wondering if you've, actually there's a question coming, so before I follow my train of thought, I'll ask Veronique's question. Hi Mary, thank you for your presentation and for the published paper. With segmentation by part, patients would now be segmented. How did this impact on their waiting time to get all of their radiology needs? Also, what was their wait? I'll read this again because
I understand.
Okay.
She's also talking about people who might need more than 1 scan on a different body part, I think. Those people, we wouldn't necessarily segment by their body part because they're going to have multiple scans. So we were looking at the ones who were purely coming in for a single scan. So.
Also, was their wait time counted from first scan or at completion?
Again, she's presuming that they're going to have multiple scans. So I would imagine if a patient needs multiple scans, most of those are done in the same appointment. So it would be at the completion of those scans.
All right, thank you for that, Mary. When you spoke about the staff being in control and driving their own work, when you answered that question before, so have you noticed any improvement in how in control of their work staff feel, or are staff more engaged in their work? Do they feel better or worse about how things are now?
Yes, we did staff surveys and feedback, but as I say, COVID has completely decimated that service. Our waiting lists are going back up. And so that planned care is going to take several years to get back. But the responses we got, and we had weekly meetings where they could come up with the ideas that we were going to test, and there was really good engagement through that.
Yep. So were those weekly meetings really beneficial for engaging with the staff and the service?
Yeah, and I think they could see that we were taking their suggestions seriously and working through them. Just jumping to the union involvement, I can't answer that, but it was a fairly standard way of working in private, so we adopted some of the staffing practices from private hospitals. And again, it was all done with the service manager, the director, and the staff involved.
Great, thank you, Mary. Are there? Oh, yep. But yes, there was. Oh, Ben.
Yeah.
Any other questions for Mary from anyone? Any raised hands or chat comments? No. Oh, yes, Carl.
So just I guess just to link that back to this idea about data for who, and I guess is that quality improvement when done well is entirely consistent with the things we were talking about before, which is that it's actually about understanding the realities of work and using data to show people and get them involved in solving the problems, which is quite different to having data that's then solved by people who don't understand the realities of work and just say, this is what we're going to do. So yeah. I think, good QI is always grounded in, the soil of real work. And so I think that's entirely consistent.
And I think understanding the importance of relationships. Who are your key people in that department? We had a very engaged MRT that ran a lot of this, and just how they worked with the other MRTs. We were on the side, but it was their project, it was their issue, and it was their solution. So we just helped. So.
Fantastic. Thank you very much, Mary. That was really interesting and very complimentary presentations. So just thank you once again, and I'll hand back to Gillian.
Again, my thanks, Mary. I think it's an excellent piece of work, and what a shame Omicron and its cousin Delta, I guess it's sibling Delta, has done it. But there'll be lessons that you'll be able to bring forward from that, and getting it back on track.
We're now looking at capacity and demand in the outpatient setting as a whole. So starting to get that rigor into understanding what our capacity is. Sometimes, like in gastroenterology, we looked at it, their capacity was so low compared to their demand. That's a different conversation. Then you have to think about how do we meet that demand in other ways. But where you've got enough capacity, then you've got, again, a different conversation. How do we match it? So I think it's that thinking. Great,
thanks very much. There are some complimentary things coming through, and we can send you the chat, and great thanks to both you and Carl for that. And we go into the wrap up now. Just remind you that we will send out Mary's paper. We've circulated to everyone that registered for the program. We will be sending you a feedback survey. Please complete it and send it back to us. We know that you're busy, but we need to know and understand to best meet your needs in the future. It would be great. Remember, the next one is same time, same place on the 24th, and we look forward to seeing most of you back, we hope, that day. And Jane is now going to close with the karakia. Thank you, Jane.
Thank you, Gillian. Kia ora anō tātou katoa, kei te whakakapi o tātou hui. No reira, he karakia whakamutunga. Kua mutu a tātou mahi. Ka tae te wā, mō te whakairi te kiti. I te kiti kōrero. I te kiti whakaro. Hei tiki atu anō mā tātou. Tauwharatia mai mātou katoa. O mātou hoa, o mātou whānau. Ai au ki te aorangi, hui e tai.
Thank you. Thank you, Jane. Ka kite anō, everyone. I hope to see you back in a fortnight.